Glycoprotein 2b3a inhibitors. Glycoprotein 2b3a inhibitors. GP2b3a inhibitors. GP2b3a inhibitors. Epiximab, trafficpan, and epitifibanide are used in patients with acute coronary syndrome for angioplasty and stenting. These agents inhibit the aggregation of platelets. Acute coronary thrombolytics, major bleeding, bowel cell pain, recent surgery, less than equal to 2 weeks, severe hypertension, greater than 180 by 110 mm mercury, non-hemorrhagic stroke, less than equal to 6 months. Morphine is not useful in MI. Treatment differences between cardiac events, aspirin, stable angina, unstable angina, and ST-eliminated angina. Aspirin, yes, yes, yes. Beta blockers, yes, yes, yes. Nitrates, yes, yes, yes. Low molecular weight heparin, enoxaparin, no, yes, and yes, but only after revascularization. GP2B/A no in stable angina, yes in unstable angina, and no in ST elevation. MI. Thrombolytics, no, no, yes, but not as good as PCI. Calcium channel blocker, no, no, no. Warfarin, no, no, no. Antiplatelet drugs, no, yes, yes. Bottom line, TPA thrombolytics are beneficial only when ST segment elevation, MI, or new left quadrant block. Low molecular weight heparin is the best for non-ST elevation MI. GP2B3 inhibitors are best for non-ST elevated MI in those undergoing PCI and stenting. Now, tip: calcium channel blockers and warfarin have no mortality benefit in acute coronary syndrome. GP2B3 inhibitors are used only with stenting. Tip: low molecular weight heparin enoxaparin is superior to unvaccinated heparin in terms of mortality benefit. In non-ST elevation MI acute coronary syndrome, all medications have been given and the patient is not better. Urgent angiography and possible angioplasty PCI should be done. No, not better means persistent pain, ST flare-up or CHF developing, worse EKG changes or sustained ventricular tachycardia and rising troponin levels. Figure 3.4 acute coronary syndrome treatment algorithm. Acute coronary syndrome, ST elevation MI, PCI available less than 90 minutes after patient arrives. Thrombolytics of PCI not available, used within 12 hours of start of chest pain. Aspirin/clopidogrel, beta blockers, statin, 18 inhibitors, and nitrates. Now, if there are not non-ST segment elevation, MI, or unstable angina, give aspirin, clopidogrel, or give low molecular weight heparin in early PCI. Complications of acute myocardial infarction. Tip: complications of acute myocardial infarction are excellent source of what is most likely diagnosis question, the most common type of question on CSME sub-CGK. Other complications of myocardial infarction can result in hypertension, so the presence of hypertension will not help you to determine the diagnosis. Now, starving heart have ventricular tachycardia, open and fast with PCI. Bradycardia. Heart rate is likely to establishing the diagnosis of post-MI complications. Silent bradycardia is very common and associated with MI because of vascular insufficiency of the SA node. Third degree complete AV block will have Canon A waves. They are the best way to distinguish third degree AV block from silent bradycardia before you obtain an EKG. Canon A waves are produced by atrial systole against a closed transverse valve. The tricuspid valve is closed because the very essence of third degree block is that the atria and ventricle are contracting separately and out of coordination with each other. Canon is the bounding jugulovenous wave bouncing up into the neck. Look for an association with right ventricular infarction and third degree AV block. All symptomatic bradycardias are treated first with atropine and then, if the atropine is not effective, by placing a pacemaker. Tachycardia, right ventricular infarction. Look for the association with a new inferior wall MI and clear lungs on auscultation. You cannot get blood into the lung if the blood cannot get into the heart. You can diagnose by flipping the EKG level read from the usual left side of the chest to the right side of the chest. ST elevation and RV4 is the most specific finding. The right coronary artery supplies right ventricle, RV, AV node, inferior wall of the heart. Now, right coronary artery supplies ST node 60% and AV node 9%. This is why up to 40% of those with inferior wall MI will have a right ventricular infarction. Treat right ventricular infarctions with high volume fluid replacement. Avoid angioplasty and right ventricular infarctions. It may markedly worsen cardiac filling. Terminates a free wall rupture. It usually takes several days after infarction for the wall to scar and weaken enough to rupture. Look for sudden loss of pulse. In the case lungs are clear, it is cause of pulseless electrical activity. You can diagnose with emergency echocardiography. Emergency pericardiocentesis is turned on the way into the operating room to repair it. Ventricular tachycardia or ventricular fibrillation. Both ventricular tachycardia and ventricular fibrillation can cause sudden death, and if they cause loss of pulse, there is no way to distinguish them without an EKG. Both are treated with emergency electrical shock, cardioversion/defibrillation. These complications are the reason patients with acute MI are monitored in an ICU for the first several days after infarction. Valve septal rupture. Both valve rupture and septal rupture present with new onset of murmur and pulmonary congestion. Ventricular regurgitation murmur is the best heard at the apex with radiating to the axilla. Ventricular septal rupture is the best heard at the lower left sternal border. The most accurate test echocardiogram for both valve rupture and septal rupture. Tip: you cannot always depend on buzzwords like step up for oxygenation. Often the numbers are simply presented to you. 70% oxygen saturation is found on a sample of blood from the right atrium. 85% saturation is found on the right ventricular sample. Look for a step up in oxygen saturation as you go from the right atrium to the right ventricle to the hand through the diagnosis of septal rupture. Intra-aortic balloon pump. Intra-aortic balloon pump (IABP) is the answer when there is an acute pump failure from an anatomic problem that can be fixed in the operating room. IABP contracts and relaxes in sync with natural heartbeat. It helps give a push forward to the blood. Tip: intra-aortic balloon pump is never a permanent device. It serves as a bridge to the surgery of our valve replacement or transport for 24 to 48 hours. Extension of the infarction/reinfarction. When a patient presents with an inferior or anterior infarction, it is common for a second infant to infarct a second geographic area of the heart. Look for recurrence of pain, new rails on exam, a new bump on the EKC KMPs, and even sudden onset of pulmonary edema. Repeat the EKG and retreat with angioplasty and sometimes pulmonaritis and adhering to the usual medications: aspirin, metoprolol, nitrates, ASC, and statin. Aneurysm/mural thrombus. Aneurysm or mural thrombus is detected with echocardiography. Most aneurysms do not need specific therapy. Mural thrombi, like all thrombi, are treated with anticoagulation. Who is most likely diagnosis? Key feature: diagnosis. Bradycardia, Canon A waves, third degree AV block. No Canon A waves, sinus bradycardia. Sudden loss of pulse, jugular distension, tamponade/wall rupture. If you have MI in history, clear lung, tachycardia, hypertension with nitroglycerin, right ventricular infarction. New murmur, rail/congestion, valve rupture. New murmur, increase in oxygen saturation on entered right ventricle, septal rupture. Loss of pulse, needs EKG to answer question, ventricular fibrillation. Prepare for discharge from hospital. Tip: do not do a stress test as the patient remains symptomatic. These people really need angiography. Do not do angiography if reversible signs of myocardial ischemia are absent or on stress test. There is no point in revascularizing the two myocardium that is death infarctus. AC inhibitors are best for anterior wall infarction because of the high likelihood of developing systolic dysfunction. For patients who experience scuff with an AC inhibitor, give ARBs. The table summarizes discharging medications for patients post-MI. The paracetamol is never the right choice for coronary artery disease. Discharge medication post-MI. Therapy and comment. Aspirin plus P2Y12 inhibitor. Continue aspirin indefinitely. Give P2Y12 inhibitor for greater than or equal to 12 months. Beta blocker, start within 24 hours. Reduce mortality as long as given before discharge. Statin, all on high-intensity statin after acute coronary syndrome. Goal LDL less than 70. AC inhibitors or such ARBs, anterior MI, heart failure, ejection fraction less than 40%. Spironolactone, ejection fraction less than 40% post-MI. Prophylactic antiarrhythmic medications. Do not use amiodarone, flecainide, or any rhythm controlling medication to prevent the development of ventricular tachycardia or fibrillation. Do not be fooled by the question prescribing frequent PVCs and ectopy. Prophylactic antiarrhythmics increase mortality. Sexual issues post-infarction. This is very frequently a tested subject. The most commonly tested facts are: do not combine nitrate with sildenafil. Hypertension can result because they are both vasodilators. To erectile dysfunction, post-infarction is most commonly from anxiety. However, of all the medications that cause erectile dysfunction, the most common is beta blocker. 3. The patient should wait until after an MI to re-engage in sexual activity. If the patient is symptom-free, sexual activity may begin in 2 to 4 weeks. A smaller inferior MI requires a shorter wait time because sex resumes than an anterior wall MI. 4. If the post-MI stress test is described as normal, patient can re-engage in any form of exercise program as tolerated, including sex. Congestive heart failure. Congestive heart failure (CHF) is the dysfunction of the heart as a pump of blood, causing insufficient oxygen delivery to tissues and fluid accumulation in the lungs. There are two causes: systolic dysfunction, decreased ejection fraction and dilatation of the heart; diastolic dysfunction, inability of the heart to relax and receive blood; normal ejection fraction. The essential feature of CHF is shortness of breath dyspnea. Systolic dysfunction. The most common cause of CHF is hypertension resulting in a cardiomyopathy or abnormality of the myocardial muscle. Initially, when caused by hypertension, ejection fraction is preserved. Over time, the heart dilates and causes systolic dysfunction and decreases ejection fraction. Hereditary heart disease is all types of results in CHF. Myocardial infarction is a very common cause of dilated cardiomyopathy and decreased ejection fraction. When the heart is dead or infarcted, it will not pump. In the United States, CHF is the most common cause of hospital admission in adults. Those with CHF are admitted repeatedly for examination. Tip: infarction to dilatation regurgitation is CHF. Infarction, cardiomyopathy, and valve disease account for the vast majority of cases. Less common causes are alcohol, post-viral idiopathic myocarditis, radiation, adriamycin, Dr. Robertson use, Chagas disease, and other infections. Hemochromatosis also causes restricted cardiomyopathy, thyroid disease, peripartum cardiomyopathy, and thiamine deficiency. Presentation: even in its worst form, pulmonary edema, CHF is a clinical diagnosis. That means you should be able to identify the most likely diagnosis from the history and physical exam without needing to do lab tests. Dyspnea, shortness of breath on exertion is the indispensable clue to diagnosis. In addition, look for orthopnea, shortness of breath that is worse when lying flat, reduced when sitting up, standing. Peripheral edema, raised on lung exam, jugulovenous distension (JVD), for example, nocturnal dyspnea (PND), sudden worsening at night during sleep. S3 gallop rhythm. On the step 2 exam, be prepared to identify the sound that may be played. The 3.5 timings of S3 and S4 gallops in the cardiac cycle. Source: EKG normal S1, S2, S1, S2, S4, S4, S1, S2, S4, S1, S2, S3, S3, S2, S1, 3, S1, S2, S3. What is most likely diagnosis for dyspnea? Key feature: most likely diagnosis is sudden onset clear lungs, pulmonary embolus; sudden onset wheezing, increased respiratory phase, asthma; slower fever, sputum, unilateral rales, bronchi, pneumonia; breathe by sound unilaterally, tracheal aviation, pneumothorax; circumvolular numbness, caffeine use, history of anxiety, panic attack, period gradual or days to weeks, anemia; pulsus paradoxus, decreased heart sound, JVPT; tamponade, palpitation, syncope, arrhythmia of any kind; dullness to percussion at base, pleurophurin; long smoking history, barrel chest, COPD; recent anesthetic use, brown blood not improved with oxygen; clear lung auscultation, cyanosis, methemoglobinemia; burning building or car, wood burning stove in winter; suicide attempt, carbon monoxide poisoning. All of these will lack orthopnea, PND, for example, nocturnal dyspnea, S3 gallop. Diagnostic test: there is an enormous difference in the management of chronic CHF and pulmonary edema in the office and a pneumatic-based setting. The key is to identify the setting, ED versus office or clinic, and whether acute symptoms of dyspnea are seen at the time of presentation.